Would you like to go, Ms. Dunkelberg, first? Thank you.
I'll be happy to, and I have some written testimony of PowerPoint slides that are being distributed. I know we need to move quickly. I am Ann Dunkelberg, Associate Director with Center for Public Policy Priorities, and I wanted to mention a couple of things before I delve into these slides just for a minute, and one is that with respect to some of the earlier discussion, and I will definitely follow up with your staff about this, I heard a lot of references earlier in the day to able-bodied adults, and one of the fact sheets that we've provided that we have on our website that I'll go around and talk to people's staff about is one that explains that, in fact, many Texans with very serious, grave illnesses do not qualify for Medicaid today. You don't get a disability determination because you have an MS diagnosis or a cancer diagnosis or even a schizophrenia diagnosis. Until you can no longer work or you're certified as being within 12 months of death, you can't get SSI. So we have tons of Texans with serious illnesses that are going untreated because they fall into that gap where they don't get the subsidies in the marketplace, but they are not sick enough yet to get Medicaid through SSI. So I wanted to mention that. And then the other thing is just to mention for future reference, and I'll be happy to come around and talk to staff about this as well, that I spent about 8 hours with the HMA report this weekend because that's really what it takes. There's a ton of good information in there, but I noticed at least 3 sort of major methodological questions about it, and one of them speaks to one of the things you've talked about today, which is they referred to the fact that they used the Urban Institute's model for their Medicaid expansion predictions. However, when I looked at their numbers, they didn't match up with the Urban Institute's. The Urban Institute predicts that the uninsured rate due to new Medicaid enrollment of the newly insured would go down by 1 million to 1.2 million, whereas this estimate is something like 668,000. When I checked with Urban, they said that their model assumes take-up rates between 70 and 88% based on the actual experience of other states, and that they had advised HMA of that, but that HMA nevertheless chose to use a 60% take-up rate. There are some other methodological issues, but I think that's one of the biggest ones that's worth noting. So there are some number issues that I won't drone on about right now, but I would love to follow up with your offices about them. And the other 2 are not minor either. The rest of my handout is really only about a very simple analysis that we did using HHSC data from the waiver. All it does is show, using HHSC waiver year 4 data, which was the last year of complete data we had, it showed what a 25% reduction in DSRIP would amount to and what a 50% reduction in UC would amount to. Even based on the HMA, everything I know still confirms that if CMS follows the rules that they are talking about, a 50% reduction is still very much likely in UC. There's nothing I found in the HMA report that really changes that picture for me, although there's, as I said, lots of good information in there. So I just wanted to make you aware that this report that we put out in July does show what a 25% DSRIP reduction and a 50% UC reduction looks like by county, by RHP, as well as by hospital. And so this is just a handy resource to understand sort of the magnitude of the fiscal impact that some of the folks that you're hearing from in your testimony are looking at. And I know I need to wrap up, but I do want to point out that on slide, well, they're not numbered. What should be slide 5, there is a chart that has some of the major counties from districts of members in this committee showing what the 1-year 2018 reduction would be with the projected reductions in the waiver that we're talking about. And I've appended 2 other slides, and then I promise I'll wrap up, which I wanted to make sure you're aware of. We have a feeling that there are many people here at the Capitol who literally do not understand that this is the situation we have in Texas. That because Texans under 100% of poverty can't get coverage in the marketplace with subsidies, their next door neighbors who make $1,000 a year more than them, the parents can get coverage for $40 a month, but the parents in the lower income family cannot. I've also gone through, I think a lot of us don't understand how many people are really working at those incomes. We have somewhere in the neighborhood of 45 state of Texas classified jobs that if you're supporting 2 other people or 3 other people at the starting wage, you'd be in poverty. Now, our state employees have some good coverage. They're not the people I'm concerned about, but it's important to understand that there are tons, especially of young families, young working families, that really are, headed by a full-time worker, and they are still under the poverty level. So I've gone on a little too long, and I thank you for your time and happy to answer any questions.
I'm just saying, Cover Texas Now is on every page here, and if you want to cover Texas, you really can't do it just through Medicaid expansion, as I've discussed and has been discussed in this committee. Why aren't y'all arguing for flexibility at the federal level so that Texas can fashion a program that covers everybody, that has co-pays and personal responsibility and a benefit design package that's changes based upon the need versus a young healthy adult that needs catastrophic coverage versus that child that was there that was a medically fragile child, instead of a one-size-fits-all Medicaid program that costs too much, that's inefficient, and is really suboptimal for population-based coverage.
Well, I think there's one area we do agree with you. We do think that Texas can and should pursue a coverage plan that includes co-payments. It uses a commercial benchmark plan and can even have things like medical savings account and a premium-like structure, as Indiana and other states have done. So we feel like there is an option there. We have yet to have anyone who argues
Indiana
for flexibility.
plan has to utilize Medicaid enrollment.
I'm sorry?
The Indiana plan has to use eligibility requirements as per Medicaid, as does the benefit design has to be consistent with the current Medicaid program.
Actually, you can use a commercial benchmark for this expansion population, and that has actually been in law for a while. I think it's really widely misunderstood. So even Indiana, now that does not mean there is no accountability or no minimum standard. So I think that sometimes that's in the eye of the beholder. For some people, if there are any floors, any minimum standards, then we don't have enough flexibility. And if that is your standard, then you're right, there is accountability that the federal government demands, that you have to meet minimum standards. But those are the same minimum standards that are available in the marketplace. So the same ones that Arkansas people are getting when they buy coverage through the marketplace. They have to have the 10 essential health benefits and those sort of things. Mental health parity is part of the law for both Medicaid and for the marketplace. But we see those things as steps in the right direction. So I think that there's a lot of room for agreement. But again, whenever people start talking about flexibility in a way that's not real specific, we want to know what it is you want to cut back on. And that's a lot of what we're here to talk about.
Senator.
I want to see if I can clarify some things that we talked about earlier, and especially at one point I made a reference to the Center for Public Policy Priorities and was, I thought, corrected on it, but we were talking about the uncompensated care study and health management associates, and I guess I was kind of thinking about the Houston Chronicle article that came out in July that basically referred to you as indicating that because the federal government would match 9 for every $1 state spent to expand Medicaid coverage, to expand coverage, Texas would net $4 to $6 billion a year, according to Ann Dunkelberg, the article said.
Well, that really wasn't my calculation.
And so I was wondering about that, because then my chairman here said, well, wait a minute, that study indicates that there would only be about 458, I think he said $458 million.
358 million out of 8.7
yeah, that's
billion
right.
For hospitals.
So I was wondering if you could clarify that as to
there's
why
actually not enough real deep background in the HMA report, which is hard to believe because it is long and very detailed, but they don't give you access to all of the details that they're assuming. But I mentioned one of the assumptions that drove that, I think, being too low, and one is that they've assumed that only 60% of the eligible adults in Texas would sign up for Medicaid expansion, which is very contrary to the experience of the states that have signed up. I know Avik Roy mentioned earlier that in the marketplace, 85% of the people who qualify for marketplace subsidies under 150% of poverty have signed up, and in some of the states with Medicaid expansion, as many as 88% have signed up. So we think, they're using an unreasonably low estimate for that. The other thing, another thing that jumped out is they didn't use the 1 to 1.2 million enrollment number that the Urban Institute did, but they did use the Urban Institute's number of how many people are in the marketplace right now in Texas between 100 and 138 who would be automatically moved from the marketplace to Medicaid if they became eligible for it. And that's kind of getting into the weeds, but one of the things that they appear to have done in their model is assume that some of those people are not subsidized marketplace members, but are people out in other parts of the private health insurance market, like group health insurance, which actually is not the case and is not part of Urban Institute's model either. And then let's see, there's a couple of other things they've done. They've assumed that half of everything that is counted currently on the books as bad debt can be reclassified as charity care, which would make it eligible for reimbursement, despite the fact that we wouldn't know whether those were services that were actually delivered under the premises of a hospital's explicit charity care policy and what their income limits are for that, or whether or not that hospital pursued those dollars as a debt. You're not supposed to be able to ask for uncompensated care payment for something at the same time that you're putting somebody into collections for that money and chasing it. So it's complicated, but it appears that there are I want to be respectful to HMA, which has a good reputation, but it appears to me that you could make an argument that they lowballed that estimate.
Did they limit also their impact just on hospitals? Was that another?
They assume a very high proportion of folks are dropping private insurance and going to Medicaid, and therefore going to a lower reimbursement rate. Of course, the lower reimbursement rate is one of the questions that comes up in this whole debate that Texas is having with the feds and other states, is the feds don't want to pay back-end supplemental payments. They want you to go ahead and make your payments adequate. They are saying they don't want to pay for what we call the Medicaid shortfall. You had a lot of discussion about that earlier, anymore through back-end payments. They want states to pay for that through their reimbursement systems. And the HMA study noted that they did the math and figured out that half of hospital reimbursement in Texas, not only, we already knew that half of it was through supplemental, but half of it is paid for with the state share being local funds. So we have a pretty significant issue with the way we're trying to get to a more adequate hospital reimbursement effort. And so I'm sorry, I've jumped from one topic to the next, but I think there's several aspects of their Medicaid expansion modeling that are questionable, and then some fascinating findings that they've done a really good job on too.
We also had some discussion. I think Senator Colkhorst brought up the issue about the coverage gap and whether people are working hard enough or not. I think as I understood it. Can you speak to this? I mean, I think you all have got plenty of information out there about these are hardworking Texans that we've got.
There's obviously a whole range of people who fall into the working poor or the non-working poor. The majority of the folks in our coverage gap are in a working household. A lot of them are full-time. Some of them are headed by a part-time worker. Sometimes they're a part-time worker because they're not very healthy, but they're not sick enough to be on SSI yet, so they don't have that Medicaid coverage, but they're sick enough that it keeps them from working full-time. Some of them are taking care of a kid with disabilities at home, and that's why they're working full-time or not working at all. We also find a lot of, in addition to those very young families, particularly if you're trying to have one parent at home with the kids, it can be really easy at a starting salary to be below poverty. And so those are working families in our coverage gap. And then we also find a significant population of women, women and men over 50, between 50 and 65. And so that's an age where illness may have made it impossible for you to work nearly as effectively as long hours at the same level as you used to. And so your earnings drop down and it's easy to be below poverty. but you're not sick enough again to get SSI and therefore get Medicaid. So that's one reason you will hear folks from specific disease groups as well as advocates for the Texans with mental illness talk about how, we could get a whole bunch of Texans who are not impaired enough yet to qualify for SSI into a medical home where they could get consistent mental health treatment if we came up with a coverage plan, including one with premiums and co-payments and incentives for healthy behavior and medical savings account, all those things that other states have added. So we really think that the opportunities are out there for Texas, and we hope that we'll start looking at the balance of benefits and
There was. Excuse
No,
me.
go ahead, please.
I've got two more. There was some skepticism also about the federal government living up to its commitment on that 90%, coverage funding, and as a match, and so. I think I made the point, well, it's not up to CMS. That's legislative. You'd have to go to the Congress and change it. I mean, has there, to your knowledge, been any instance where the federal government has backed down on some of these?
Not on Medicaid or CHIP. We don't have any other comparable programs where we put up, billions of state matching dollars. So I think it's really important to understand that there is not a history of that. In fact, in CHIP, the match rate has gone up to between 90 and 95% now. So it's almost all federally funded. It's also a very small program in Texas relative to Medicaid for children. It is also the case that we heard those concerns. I've been here so long that we heard those concerns back when we were debating creating a children's health insurance program in Texas. And one of the things that Texas did was put into our CHIP bill a trigger that said if the feds back off on their, what was then a very generous match rate of around 75% on this, this is grounds for repealing or, going back to the drawing board. It hasn't happened before. What has happened, what the feds have allowed to deteriorate, and what Congress has allowed to deteriorate often, are block grants. So we have block grants like the Maternal and Child Health Block Grant and Title X and the Mental Health Block Grants, and especially the TANF Block Grant, that they've not made any attempt to keep up with population growth or inflation. Now, the CHIP Block Grant, they have kept up. So that's why when people ask about block grants, I say, you and I might create really different block grants. I could create a block grant that I would feel reasonably good about, but if it's one that Congress is going to ignore for 3 decades and every year it will lose buying power, that's not necessarily a good deal for Texas.
To that point, the Roberts ruling negated the mandatory expansion of Medicaid because of the coercive effects, and we as states are having left to deal with the issue of this coverage gap, which is in part of the ACA legislation, and it's incumbent upon us, but isn't it also incumbent upon Congress and the federal government to work with us to solve that regarding flexibility and options that the states seem want to fashion a program that's correct? I just don't believe that flexibility has been offered to the extent that is appropriate for equal partners. Do you think the federal government is being all...
Well, Congress has not been very productive by almost anyone's measure on either side of the aisle, I would say, for the last several years. And certainly, the idea of tinkering with the Affordable Care Act has not been something they've wanted to talk about. But I think my impression is that I have watched CMS go further with states like Indiana and some of the other states than I would ever have dreamed they would have gone. They have really pushed things. In my circle of advocates nationally that I communicate with, the fact that I'm willing to come to the table and say, give me
but they
an
went back on
alternative coverage
Indiana
program.
In Indiana, there was a program that had co-pays and premiums, I believe, and CMS said, no, you can't do that. For that population, we got to treat everybody equally, and therefore you got to expand Medicaid if you want to maintain that program. So it really was more the hammer than the carrot.
They wanted to not expand Medicaid, and I think that's correct.
They wanted to maintain their program that they had in place, and the only way to maintain that existence of that program, because of the coercive effects of CMS, was to subsequently expand Medicaid.
That's correct, and I think there may very well be a really fundamental philosophical difference in terms of
the role of the
federalism.
government.
In other words, I kind of think that everybody in the United States should have roughly equivalent access to things like education and health care. There shouldn't be a giant cliff when you cross the Red River. but other people's idea of what they would like to see the country be does not include that. I was somebody who did not think that the idea that we could block grant Medicare in Texas was a great idea, but people in this chamber voted for it. So I know that there's diversity of opinion on that. I feel like there's a lot of flexibility there. There's not. Most of the time when I talk to conservative members, the things that they talk about are some of the things you mentioned, like premiums and co-payments and personal responsibility requirements and medical savings accounts. And those are things that are, in fact, happening in other states. And some of my colleagues in the world of advocacy for low-income uninsured think that that's terrible. But I think that I would be happy to see a program like that in Texas. I think that would be a huge step forward for low-income Texans. So.
I think our degrees of freedom are different right now. Thank you. I appreciate it, Ms. Dunkelberg.
No, you just prompted me to ask one more question.
Yeah, go for it.
If I might. Ms. Dunkelberg, we've got 32 states that have, in fact, expanded Medicaid, and we've been concerned about that in part because of the impact it might have on the state budget. So do you have a sense of what impact those 32 states have had on their budget as a result of the expansion? Bad, good, indifferent?
The analyses we've seen is that there are some significant state savings when states do the expansion. Of course, we've missed out on the first 3 years when we would have gotten 100% match, federal match for those. But states have had some really big GR reductions because you can convert, as you know, we pay for more than half the babies in Texas with Medicaid maternity coverage. You can convert most of those into women who are in a medical home and who are earning that 90+% match rate if you do Medicaid expansion. You also can, these are just some of the really direct effects, you can also pay for most of your inpatient hospital care that you deliver to people who are incarcerated if you do Medicaid expansion. So those are really direct. And most states see some significant reductions in what were previously 100% state-funded mental health services, but I don't think you can generalize about that because it really depends on, every state has such a different system in how they fund those things, and so I wouldn't want it to sound like I was advocating rolling back our community-based mental health plans. There are also some, which is why you hear sheriffs and county officials talking about needing a coverage solution, the ability to get particularly people who have repeated contact with the criminal justice system, as you've heard about from some of the other speakers today, who cycle through the jails and the emergency rooms, the ability to get them into a consistent source of financing for their mental health care. It's not a panacea, but it's a big step towards reducing some of the high cost hospital utilization. So you have the states that have put out analyses have showed actual GR reductions as a result of their Medicaid expansion. That does not mean there are no state costs. When HHSC did their last public fleshed out model of Medicaid expansion, they showed some significant costs for the state, but they also showed a net gain of federal funding after you net out all of the state costs of $6 billion a year or more over a 10-year period. So, this is the struggle we have. Yes, we would have a state share, and starting in 2020, it would be as much as 10% for this population group, but there are all kinds of offsets to GR as well as increased tax revenues and job creation that can come along with having another $4 to $6 billion a year in your healthcare economy.